Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to Pod Patrol with your host, Dr. Jeff Dykes.
Dr. Leland Jaffe.
And very special guest host,
Dr. Ashley Dykes.
All right, thanks for joining me today, guys. How are you guys doing?
Good.
Good, you?
Ashley? Good. Ashley, I haven't seen you in a couple of minutes. Leland, it's been a couple of weeks.
Yeah, no, it's been good. It's been, we had spring break here, so that was a nice little reprieve. Good to always recharge the battery a little bit.
Yeah, did you guys go somewhere?
Yeah, this was our redemption trip. Our previous trip, we were in Hawaii, so we were there for the Lahaina fires.
I remember
that was a little bit of a harrowing experience. So this was our attempt to have a successful family trip. So it worked well. We were in Puerto Vallarta, Mexico, for about 5 or 6 days, and it was just 80 and sunny. Can't complain.
Good.
Yeah,
Awesome.
yeah.
Well, Ashley and I are coming off the heels of each of our teams being in the national championship. My Iowa women's basketball and her Purdue men's basketball were both made it to the finals, but both came up a little bit short. So close, but second place is the first losers. So
I don't know about
it done this year.
I was rooting for both of those teams. I went to University of Illinois in Champaign, so I'm always going to pull for the Big Ten if possible.
Sure.
I hear that.
Well, it was fun to watch. Kept us entertained.
It was fun
for a while.
Mm-hmm.
It was fun.
So I thought today would be a good time to go through Achilles tendon injuries. Seems like it's been in the media a lot, specifically when famous sports, professional athletes sustain that type of injury. It tends to get more traction with the general population. And obviously we see Achilles tendon injuries every day. So I thought that'd be a good topic, kind of one of these initial broad topics for us to kind of tackle and then dive a little deeper. Obviously our goal is not to sit here and give a lecture. That's not really our goal. We're trying to provide some additional insight to these injuries for people that they may see in some ways to kind of go about it that seem to have been successful. So Ashley, how often are you seeing these, both now and at your last job at the orthopedic group?
Yeah, I'd say in my last job, I was seeing a lot more of the acute injuries, and now in my current position, it's certainly much more of those chronic tendon injuries and the sequela we see from that.
Yeah, so I think that's kind of an interesting distinction to make, is that chronic long-term Achilles tendonitis, which becomes a tendinosis, is treated a lot differently than an acute injury, whether it's a tear or not. But an acute injury is treated a lot differently than that chronic thing where it's become, calcified and degenerated, right, and it's not pliable, mobile anymore. And it's just kind of this big ball of junk back there. Or they have a large osseous prominence. Those are an entire different beast from an Achilles tendon rupture. So I end up seeing this quite often. I think I saw 3 tears this week. So I do end up seeing it. Yeah, exactly. So, but that doesn't mean they all need surgery. So we'll kind of dive into, what I tend to think about when I see these injuries and which ones end up needing surgery and which ones don't. But let's kind of jump into it here.
I think Aaron Rodgers brought this on the map, right?
Yeah, he did. And then there were a couple other maybe lesser named guys that sustained Kirk Cousins, obviously, but then a couple of lesser named guys that had some as well, including that one guy that was in the Super Bowl poor guy was running on the field, his dream of playing in the Super Bowl, and just popped.
Yes, I do remember that. Now I always feel badly for these guys. They they tear their Achilles, and then on social media, everyone just sees their calf muscle reverberating in slow motion.
Watching it on repeat.
Replayed over and over again.
Yeah.
I think I remember a clip of Kobe Bryant tearing his Achilles tendon and then went on to still shoot his free throws and sink them before getting pulled from the game.
Yep, I believe you are right. So
yeah,
I've never obviously torn my Achilles, but I hear some people say that after they've torn it, that it actually doesn't really hurt. And some people say that it hurts horribly. So I don't know what the reasoning is behind that, but I certainly see both ways, right? Kobe must have either been running on adrenaline or toughness factor or something to be able to stand out there and shoot free throws after it tore.
I thought you were going to say after you repaired it, actually gets stronger and you can jump higher. Kind of like, I'm going to age myself, but the movie Rookie of the Year, when he tears his shoulder or something, they repair it and he can just whip 98-mile-an-hour fastballs.
Oh, yeah. Rowan Gardner.
Yeah, exactly. I thought you were going down that road.
Oh, I've seen that movie 100 times.
I'm looking for Henry Rulenfurter. Ravenboozer. Gardenhoser. Rulengroder. I never doubted him for a minute. Hey, way to go, run mucker. Rowan Gardner, you're going in.
What do you call me?
All right. So Achilles tendon, injuries, tears, and surgery. So when we have a patient that comes in with Achilles tendon pain, Ashley, what's your initial workup look like?
I mean, certainly you've got it listed here, but physical exam is going to be the first thing that we focus on, and it's a palpatory exam to see if you can actually palpate. Sometimes you can actually visualize, a defect or a dell, but certainly it's going to start with a thorough physical exam. We have a lot of different testing exams that we may utilize, Thompson test and others. So certainly start with that physical exam.
And Leland, if it gets to the point, so I assume at least when people come into my office, they kind of just, everyone with any pain or any injury, they just get an x-ray. Just if it's an ingrown toenail, no. If it's something, a wart, no. But pretty much anyone with pain or an injury gets an x-ray. But beyond that, what do you tend to favor for Achilles tendon? Do you do any ultrasound or do you jump to MRI?
Yeah, I personally don't do ultrasound. I think using a good musculoskeletal ultrasonographer is definitely valuable if you have that skill set. But yeah, in our practice, pretty similar. We're going to get an x-ray on most of these patients that come in with just generalized pain. And then if I'm not really sure on the absolute diagnosis at that point regarding the soft tissue injury, then likely just going to move to an MRI.
Yeah, I tend to agree with you. I just default to the MRI. I don't do ultrasound. It's not for lack of wanting to. I think that is a very valuable skill if you can do ultrasound and if you can get good at ultrasound. You have it in the office. It's pretty instantaneous. I have seen people before that I was fairly convinced they didn't have a rupture that did have a rupture on MRI and vice versa. You get it back, it's either a partial tear or it's not torn. So
how quickly are you typically able to get that MRI? Because what's your turnaround time usually look like?
I can usually get them back into the clinic in 2 to 3 days. We have, the benefits of, modern medicine and in my multi-specialty clinic, we have teams of people who do MRI authorizations, and that's all they do. So we have MRI in our building. We get it done, flip around. I see them back as soon as possible for this specifically.
Yeah, what I was going to say is, are there any downsides to getting an MRI?
The biggest downside for me is cost. Well, not me. The biggest downside for the patient is cost. They're not cheap. And so you could certainly make the argument, okay, it's torn, you're going to do surgery. Why do you need the MRI? Why don't we save some money? But I have, like I said before, I have thought, okay, this is torn, and they get the MRI and it's a partial tear or not even torn. So when we do a physical assessment for these patients, we're going to palpate, see if we can find that little void in the tendon, check their plantar flexion strength. I have been tricked a little bit before. I don't know if you guys have, where you tell them to plantar flex and it doesn't feel that bad. They're recruiting the other flexors and you can certainly get tricked. But as soon as you put up their contralateral extremity and you tell them to push on both, you can feel that instant difference. So don't just test plantar flexion strength on the one.
I agree with you. And I have a good video that I could share at another time. But I have a patient of mine who I did a subtotal calcanectomy where I took out 90% of the calcaneus and debrided about, 6 centimeters of the Achilles tendon that was all infected. And we have some video post-operatively of him having some decent plantar flexury strength with 0 Achilles tendon. So yeah, I absolutely agree.
Ashley, do you end up treating Haglund's deformity as a sole diagnosis? Because I don't tend to put too much stock in that as its own thing. If I see it on X-ray, what do you think about Haglund's?
Yeah, no, I mean, I think, certainly obviously for some people it is prominent and it's painful and causes issues, but I agree. I don't know that it's something that, there's different morphology to the posterior aspect of the calcaneus for different patients, and some people it bothers them and some people it doesn't.
What do you think, Leland?
Yeah, I mean, I think simple shoe gear modifications are usually all it takes if that's truly the primary source of pain. Honestly, I can't remember the last time I just resected a Haglund's by itself.
Right, exactly. And that's kind of my point is, in my mind, the Haglund's is contributing to a bursitis, which is inflammatory and causing inflammation at the insertion of the Achilles, which is altering the function, potentially leading to enthesophyte and chronic swelling and pain. So the Haglund itself may be driving some of the deformity, but I don't think it is the deformity itself. I think it's contributing to the development of some pathology, kind of maybe 2 or 3 steps down the road.
Mm-hmm. Yeah. One point I'd like to make here, and why we're on the point of diagnoses, more so for the students, is oftentimes, and again, when we make the distinction between acute and chronic, the point I'm trying to make is more chronic pain. So people coming to our outpatient clinic that have had months of pain on the back of their heel, oftentimes I'll certainly ask the students, what are your differential diagnoses? And, sometimes we'll get some reasonable answers, but a lot of times it's like, oh my gosh, I just don't know. Or that deer in headlights look. So one thing I always remind the students is you don't necessarily need to have a lot of experience to come up with differentials, but you need to know your anatomy. So what is back there anatomically and what is back there that could hurt, right? So we have tendons, like you mentioned, we have bone, we have joints back there. The ostrigonum syndrome is back there. We all learned about that our first year. So, think again anatomically what's in that area, and then that should lead you to some potential differential diagnoses.
I think you just summed up being a doctor. I think that's you know what? Being a doctor is anatomy and knowing what's in that area and knowing what could hurt. And I think that's a great point you just made. Simplifying it from that standpoint. I don't care what body part we're talking about, whether it's the big toe or the knee or the organ system gets far more complicated. But if we're speaking strictly from an orthopedic standpoint, wherever that pain is isolated, there's only so many things it can be. Okay, my big toe hurts. Is it, a tibial stress fracture? No, it's not, right? It's not.
Right.
It's just not that. You can rule out 95% of the things just by the anatomic location. So I think if you stop and you simplify and you think, okay, well, what are all the things it could be, and narrow it down from there, because of those things it could be, you could probably put them in a pyramid of which are the most likely, and keep the lesser, the tip of the pyramid, the little tiny possibility of that in mind. But it's probably going to be whatever's at the base of the pyramids.
Yeah, at the same point, afterwards, we come up with some differentials. I'm like, well, how do we come to a diagnosis? And again, there's sometimes a blank look, and I try to teach it more categorically, right? There's just so many things we can order. We have labs, we have imaging, and we have microbiology, right? It doesn't really fit probably into the labs or the imaging, or the microbiology, but imaging, right? There's just so much we can order. So break it down, make it simple.
I agree. I joke with the students that I could be replaced by a vending machine. If someone walked up and they just said, "Hey, my foot hurts," and then you point on the screen, "Hey, where does it hurt?" "It hurts right here." And then out pops a brace or a boot or a Medrol dose pack. Like, I could easily be replaced by a vending machine if you just type it. "Oh yeah, it hurts right here." Boop. Oh, there's your boot. All right, check me back in 2 weeks. If that doesn't work, hit the vending machine again. We'll try something else. Obviously I'm joking. You have to have the knowledge of anatomy and differentials and figure out when something is surgical versus non-surgical, but sometimes it feels like that. I see patient after patient like boot, brace, heel lift, boot. Oh, we got a surgery, right? That's when you don't need the vending machine anymore. I need to step in and do something.
There you go.
So obviously we're going to start with X-ray. So if anyone is listening only, the X-ray on the left is a lateral of an ankle, and they do have that Haglund's prominence, that kind of dorsal posterior enlargement of the calcaneal tuberosity, but this one also has a large enthesophyte at the posterior aspect. So that tells me that there's we'll call it congenital, because I think most people are born with that Haglund's deformity, just the shape, the morphology of their bone. But then they have a developmental issue with the enthesophyte at the posterior aspect. So Ashley, when you see that, what's your first kind of workup from a treatment standpoint for something kind of just enthesophyte, Haglund's, heel pain?
Well, certainly, I think, as Leland already mentioned, a lot of it is looking to see, what does their current shoe gear look like. A lot of things can be addressed when when you look to that first. So it's the simple things, right? I think it's then becomes maybe things like orthoses, heel lifts, and then oftentimes it may be stretching protocols, physical therapy. We start to go down that road.
Yeah, I think a $7 heel lift. I'll pull up Amazon in the room and I'll say, look at that one. That one looks good. That one has, good reviews. I used to keep heel lifts in the office, and the reimbursements, we don't need to get in all that. But I just tell them, hey, go to Amazon, pop in this heel lift. You can do one or you can do both if you feel kind of uneven or feel weird about having one. And just do that for, a week or two and see how it feels. Is it going to undo your Haglund? No. Is it going to fix your giant chunk of bone pushing back there? No. But is it simple enough? I tell people, you lift your heel up, it puts a little bit of slack in the tendon. It may not seem like much, but over the course of thousands and thousands and thousands of steps, maybe that's enough to kind of make it feel better. What do you think, Leland? Do you agree with that?
Yeah, I agree with everything. The only thing I would add, just to be more specific too, is I try to show them eccentric stretching exercises, and I have a couple of videos that I made to show them specifically how to do them. But in terms of stretching, that's what I try to demonstrate for them, because I think that has the strongest evidence in terms of stretches to help with Achilles pathology.
Stretching regimen is very reasonable. I have a little handout I give them, say just try these. Now, on the other hand, though, sometimes people come in and everyone has access to Google these days, so they've sometimes tried this, and I rubbed apple cider vinegar on it and I soaked it in bleach, and you're like, whoa, wait, you did what? No, who told you to do that? I get people doing all kinds of crazy stuff. So, and sometimes they've tried some of that simple stuff. So what would be your next modality for treatment options, Ashley?
Well, I think it depends on the pain level, because I oftentimes will talk with patients and say, we kind of will hit this point where it's either your pain and you're coming in and you're a 9 or a 10 out of 10. If you're at that level, having that much discomfort, then typically there's going to be at least a period of immobilization in a boot from my standpoint. Otherwise, then again, I will often go more the route of, formal PT referral, talking about anti-inflammatories, some activity modifications too. If there's somebody who, is going on a 7-mile hike every day, I don't know, whatever it may be, we may need to make some adjustments from that standpoint.
Yeah, I think physical therapy is a good idea. Leland?
Yeah. A point that I just thought of that I think it's important to make is patients that come in that have tried all these things or supposedly have said they tried all these things. I think you have to be careful taking that to heart and then saying, okay, you've tried all this, let's just go to surgery then. Because what you need to demonstrate is that patients have failed a reasonable amount of time of high quality, non-surgical, conservative care. And you really can't show that if you're just going by their word of mouth of what they said. So, just be careful.
Yeah, I think that's a good point. I have patients who will come in and they'll say, oh, I've been doing the stretches. And then I'll say, well, how many times a day? Well, not every day. Okay, well, how many times a week? Well, I did them for, I think 3 times last week. It's like, okay, that is not what we're talking about here. And if that's what you meant by, doing the stretches, then you and I have a different idea of how much benefit you might be able to get out of this. So I think that's a fantastic point, is drilling down with them and figuring out, okay, did you do the stretches? Did you?
I know
I
would probably be a bad patient. I don't think I would have the time to come home and stretch every night, every morning. It's tough.
Yeah, exactly. I'm a horrible patient. I've had some back pain in the past and did some stretches, and then it's the instant that it feels better, nope, no more stretches.
Exactly.
Like, do you want it to come back? Like, well, no, but like, that seems like a lot of work. I'm gonna roll the dice. Well, hopefully it doesn't come back, but I'm
Exactly.
I'm just gonna see how it goes. The X-ray on the right has those calcified areas within the tendon that make me nervous. Those make me very nervous because I know that the tendon is not right. It is not normal. Ashley, when you see those calcified bits of stuff there, what are you thinking?
Well, I know it's not anything new, right? Like this has been going on for quite a long time, likely. When we start to see that, especially when they're that, far proximal, I'd be probably pretty concerned about the integrity of the entire tendon at that point.
So let's go back to the one on the left again with that kind of invasive, the chronic thickening of the Achilles, most likely with just chronic long-term pain. Ashley, what are your thoughts on a steroid injection for that?
I don't offer the steroid injection, intratendinous or around the tendon there at the insertion. I just think, again, based on the literature that we have, good or bad surrounding this, I just still think just the risk with rupture is too high in my mind.
Leland, do you think the same?
Yeah, likewise. I can't justify putting steroid into that tendon. I mean, I'll certainly offload them, put them in a boot, but I'm probably not going to put steroid anywhere near that.
Yeah, I agree with you. There's only a very, very few people that I would even consider it. I don't think I've ever injected the Achilles with steroid. I don't think I've ever done it. Some of the research is a little mixed. Most of the research says not a good idea, increases the risk of rupture. Now, what is it? Does it increase at 1%? Does it increase at 80%? There's a big difference there. Some studies I've seen as I was kind of reading to prepare for this are in favor of steroid injections and said they found that it to be relatively safe. So I bet there's a portion of our listeners out there who are thinking, I do it all the time. It's fine. I'm not a proponent of it. I'm not a big fan of it, except there's 2 times where I will inject steroid into something that probably you shouldn't. And that is into the plantar plate, second MPJ capsulitis predislocation syndrome, and the Achilles, knowing that you are increasing the risk of rupture. So in a plantar plate, if I inject steroid and it tears, I tell the patient, you were headed for surgery anyways. And I tell them that ahead of time. You're headed towards surgery. We've tried this, and this. There's something else I can try. It may increase the risk for rupture or tear. And then you would get surgery, but you're probably headed towards surgery anyway. So I'll do that in the second MPJ for plantar plate, knowing that it could increase the risk of rupture. And I've seen it. I've done injections and seen it rupture. And that was my only thinking from an Achilles standpoint is like, all right, we failed everything else. The surgery potentially is, well, we'll get into the nitty gritty of what the surgical options are later. But, undergoing this big detachment, reattachment surgery is a relatively big deal. Maybe the steroid helps, maybe it doesn't. I just haven't been able to pull the trigger on that.
Yeah, I mean, to me, steroid, I always try to think, what am I doing by putting steroid in there? And steroid is catabolic. It breaks down. It's an anti-inflammatory, so it can certainly help with inflammation, but there's other ways to obtain that. I'm trying to think, okay, well, how do we rebuild? How do we, anabolic rebuilding? So, I mean, I could be in favor more of things that are more regenerative, PRP perhaps, or some of those other types of treatments that are more regenerative in nature. But, something that I know breaks down collagen, putting it into tendon to try to help heal the tendon, to me, just doesn't make a whole lot of sense.
Yeah, I completely agree with you. I'm not a huge proponent of PRP, but this would be a very strong argument for using PRP over steroid. Some of the studies have shown PRP to be semi-equivalent to steroid use in plantar fasciitis, where, in this, when we're dealing with a tendon instead of a ligament, I think PRP would be way preferred to a steroid, like you mentioned.
We might get some hate mail over that then, huh?
Yeah.
We're going to get hate mail no matter what we do.
All right, fair enough.
Angry group of people, no matter, you could be like, it doesn't matter. It could be going to like a little crocheting festival, and there's going to be a little like group that, oh, you're not supposed to do it like that. I don't know. Some people are just mad at the world. All right. So this is an Achilles tendon on MRI that is normal. So what I'm looking for when I get an MRI is that thick black line inserted into the posterior calcaneus that's relatively equal for the majority of its, path up the posterior calf. And then it kind of thins out as you get into the aponeurosis and the, gastroc-soleus complex up there. But that thick black line kind of extending from where you see it here down to the insertion. So no inflammation, no partial thickness tearing, no damage or disease within the tendon itself. That nice, thick black line. You guys have any thoughts about that?
No, I agree. No, I mean, like you said, you're just looking for anatomy. And I think you look at enough of these and you get a good feel for what a normal Achilles tendon should look like. And so then it becomes easier and easier with time. I think, especially again, from a student standpoint, just because I work with students so often, reading MRI can be really challenging at first. And I think it's something that, luckily, though, with a lot of practice, you get pretty used to what normal anatomy looks like. And so you can kind of pick out that pathology a little bit more easily.
Yeah, I always like to see on the lateral MRI too the continuation of the plantar fascia from the Achilles tendon. Just kind of reemphasizing how you can resolve some plantar heel pain with lengthening that Achilles tendon as well. Just seeing how it's all contiguous. I always find that cool to see.
So in one of our previous episodes, Dr. Burns brought up a good point, and he said, every time you get an MRI, you shouldn't just be looking at the pathology for that one specific patient. You should be looking at all of the anatomy. So this is actually an MRI of a patient who came to see me for something else and did have some pathology in a different area. But then it just so happened, because I'm not going to order an MRI for a normal foot. So it's kind of hard to be, well, how do I get a normal MRI? Well, maybe you do, maybe you don't, but the pathology is elsewhere. But it just so happens that this is a normal component of an MRI for a different problem. And so as you're a resident, a student, and even a young attending, or even who cares how old you are, you can always look at all the aspects of an MRI and see some variability. It's very interesting to me, the anatomic variability that we see throughout all humans. You can get 25 MRIs and the posterior talar process is going to look different. The insertion of the Achilles is going to look different. That Haglund's, that morphology of the posterior tuber of the calcaneus is going to look different. Everything might be just a little bit different. So I think those are good points. The more normal MRIs you look at, or at least normal anatomy part of an MRI, the more beneficial that's going to be for you in the long run.
Good point.
And so then this is an alternative slice to look through of the MRI with a T2 and a T1. And I'm typically looking for that little kidney bean shaped posterior calf to look at the Achilles. And this is where you can really get a cross-sectional analysis of inside the tendon as I scroll down to look and see if there's little striations, little white dots or lines that could indicate partial thickness tearing. If that tendon is intact with an intact peritoneum, it tends to be uniform in its shape and color. And if it has those little striations, sometimes it means that there's a longitudinal tear of the peritoneum or of the tendon itself that's allowing some inflammation to occur within the tendon itself. I always look at all my own MRIs. I end up finding things that they don't see because they don't have access to the patient. They don't examine the patient. They don't know that their pain is posterior lateral, and then they see, oh yeah, you have a chronic deltoid injury. Okay, well, great, but that's not really where they're having pain. I've seen the patient, I've worked up the patient, I've examined the patient, I know where their pain is. I'm going to be able to identify maybe something that they couldn't or didn't see.
Right. And that was the point I was trying to make earlier, where I think MRIs can be overread sometimes.
Mhm.
So, I agree. I think making sure you correlate the imaging to your physical exam is important, rather than just relying on the radiology read.
Right. I always pop it up in the room with the patient too and kind of scroll through and show them. They seem to like that. They seem to enjoy being able to see that. So this is an MRI of T2, T1 of a partial thickness. So this is the same patient with that calcified piece that was proximal. This is the same patient. He had calcified insertional Achilles tendonitis that was distal, and then whoop, tore. Part of it went up. This is a partial thickness tear. When you scroll through, it's about 50%. So this was a middle-aged gentleman. So partial thickness tear. I treat this non-operatively with a cam boot and Achilles heel wedges. Put 4 Achilles heel wedges into the cam boot, put it in plantar flexion, have them try to stay off of it for a couple weeks. Then I pull out 1 wedge. I leave all the wedges in for at least 2 to 3 weeks, and then I'll pull 1 wedge out per week. Do you guys treat this any different than that?
No, I think that sounds appropriate. I think earlier in my career, I was probably quicker to pull the trigger on fixing these surgically, and I have definitely slowed down in terms of giving patients the opportunity to treat these non-surgically. So, I would echo what your protocol is.
So I completely agree. Earlier on, we need to get in there and fix this. And for a variety of reasons, whether it be age, diabetes, I had a patient one time who I scheduled for an Achilles tendon repair who found out they were pregnant because I scheduled their surgery. So, good morning. Hello. We're not fixing your Achilles. By the way, congratulations.
How did that go over?
You are pregnant.
Yeah.
That was a little bit of a shock, but it worked out in the end. And that particular patient healed perfectly with non-operative. I didn't have another choice. Healed perfectly with non-operative treatment of an Achilles tendon rupture. So, the studies are a little mixed, re-rupture rate, and then certainly in the operative group, you have an increased risk for complications, which makes sense. But for something like this, I agree with you. I used to treat things way more surgically and have kind of tended to kind of pull the reins back a little bit. Here's another one. This is a full thickness tear of an Achilles tendon. And this is someone who did undergo surgery. And we'll kind of talk about that here in a little bit in terms of surgical intervention and treatment options. But this is a rather proximal tear. You can see there they measured 8 centimeters from the insertion. So you're starting to get up into the area where I'm doing a gastroc recession. I mean, you're starting to get up there. This is so proximal that I can't even really see the proximal stump of the Achilles tendon. It is torn and retracted so far proximally that the MRI doesn't even include it up there. So I know going in, that's the benefit of ordering an MRI. I can then isolate where is the defect, where is the void, so that I know when I make my incision placement, okay, I know it's going to be, it's going to be way up here. I wouldn't normally tackle that up that high, but I know that it's going to be much higher than I would normally go for this because I fix it with a percutaneous approach. So my incision is, 1.5 inches. And if I make that in the wrong place, well, then I'm extending. Where is this thing extending? All of a sudden, you might as well just do an open approach because of how big your incision is. So that is a reason to get the MRI because you can see exactly how big the defect is and how far from the insertion is the tear. What do you guys think about that? Does that change your treatment protocol for how proximal or distal the Achilles tendon tear is, or you just know, hey, it's torn, we're going to go fix it, I don't really care where it is?
I mean, to me, it's more not so much where it is, but how much of a defect there is in terms of planning. Am I going to be able to get that gap together? Do I need to anticipate some type of VY lengthening or FHL transfer or something more than I'm expecting to go in to do? So that's for me more the decision, not so much how proximal or distal the actual tear is.
So, Ashley, what do you consent them for? If you're going to go in and repair this, what are you consenting? Are you consenting them for anything you're going to possibly do? FHL transfer?
Yeah. I mean, I think you have to. I think you have to have all of that, plan B, plan C, plan D, and everything ready because certainly you're able to kind of sometimes make those changes in the OR, call out to family, get additional consent. And it's just obviously much more straightforward if the patient knows these are all the different things that we may have to do. Ultimately, it's to hopefully get you the best outcome as long as you're on the same page. Then I think you have to have everything kind of ready and be prepared. And that potentially may mean having additional anchors or other, hardware available as well.
So what's your threshold for doing an FHL transfer? So what would you get in there and you're trying it? Is it just not being able to get adequate length or reapproximation, or what's your cutoff for doing an FHL transfer? Do you have a short leash for that? Do you really just save it for the worst of the worst? Or how do you decide when you get in there if you're going to do an FHL?
I think for me, the FHL tends to come in more when you get in there and realize that the tendon that's there, that there is that chronic tendinosis and the tendon quality is just so poor. So I don't see a point in taking two ends of really terrible tendon and trying to put it back together because I think that, again, the long-term outcomes for that patient just aren't great. And so in those times, if I'm realizing the tendon quality overall is just poor, that's where I'd move more towards, the FHL. Otherwise, if it's more length as an issue, as Leland mentioned, you'd be thinking more, V to Y and some of those other, techniques instead.
Yeah, I think those are good points. So basically, I think what you're saying is you kind of know going in is the patient, 55 years old, obese, diabetic, chronic, acute on chronic rupture. Well, I'm very much going to lean towards FHL transfer versus a 20-year-old who was out playing basketball and just had an acute injury. So here is the MRI of the Achilles tendon rupture. You kind of going along. Okay, there's that. Oh, where's the Achilles? There is no Achilles there. There's an empty, hollow white circle where the Achilles should be, but no actual tendon in there. So it's kind of interesting. You can see the peritoneum, you can see the surrounding musculature of that area, but it's now just an empty tube where the Achilles tendon used to be. So obviously this is not a tricky MRI. This is not a, honestly, this might be something they show you in like interviews or something and expect you to understand, well, why is it white, right, versus black? So that may trip a few people up because on the other view, you're like, oh, Achilles torn, boom. But on this view, they might show it to you and let you kind of stumble a little bit. But other than that, in the real world, it's torn. I'm using the MRI more surgical planning than anything else. I just think it's interesting to look at. So for that first patient that has that large Haglund's deformity with the large enthesophyte, I still prefer the open detach reattach. I've seen people kind of moving to an MIS approach, which makes sense to me from a bone standpoint, but does not make sense to me because we know that Achilles tendon itself is going to be thickened, chronically scarred. It's going to be bulky. It's going to be just bad tendon. So if you do an MIS approach, you stick a little burr in there, shave it down. That's great. But the Achilles is still diseased and scarred. Leland, what do you think about that? What would you do for this patient with this large enthesophyte Haglund's deformity?
So in my experience and what I'm comfortable doing is basically an open detachment, reattachment, debridement. I'm usually debriding upwards of 50% of the tendon. So again, I agree. I'm not sure how I'm going to do that. Through a minimal incision approach. And again, kind of talking about FHL transfers, if you have to debride a lot of that tendon because it's diseased, another indication to perhaps grab that tendon, especially in a patient that has a high functional demand where you're trying to get them back to a certain level of exercise and activity. So yeah, I'm just more comfortable opening it. So yeah, I was gonna, ask you guys as well too, because I've been seeing more, and I don't have experience doing that Zadig osteotomy where you're just advancing everything anteriorly, but not really debriding anything. I mean, it's definitely another approach. I personally don't have experience in that. Have you guys seen that, or do you do that?
I don't. I've seen it performed once, like during training, but
Sure.
but otherwise, it's not anything that I've done.
Yeah,
I do not do it. It seems kind of reasonable, but also feels like sweeping something under the rug. It feels like just kind of like, yeah, we know there's this big problem. Let me just kind of move it over there. And oh yeah, now don't worry about that. Well, why is it still there? Oh yeah, but don't worry about that. It's kind of like, I don't know. Why don't you just fix the problem? Why don't you just like go 100%? If you're going to go 50% of the way and be like, it should be okay, why don't you just go 100%? Why don't you just do it all, fix it, be done? Now, I know that people have good outcomes. How long-term are they? I don't know. But it also looks weird. You're changing the function of the calcaneus. You're changing the function of the Achilles. I'm not a big fan of changing the function of something. There's a way to kind of remove the etiology of pain, which in this case is diseased tendon and large bone. And there's another way, which is just kind of moving it or hiding it, which I'm just not a huge fan of that, to be honest with you.
Yeah. It's like hiding your vegetables under your pasta as a kid.
Yeah.
Yeah. What is your preoperative discussion for patients regarding managing their expectations before this type of surgery?
So, I mean, I think, expectations as far as like any time that we're dealing with for these, I think in a more chronic situation, and certainly even in the acute ruptures, I mean, this is probably not going to function exactly as it always, did before. We're not bringing you back to like your pre-injury or pre-degeneration state. So I think it's all about pain control, right? We're trying to decrease pain and hopefully make you more functional. So certainly that's something that I try to set that expectation of, we want to get you to a point where this, causes you less discomfort. We're never promising zero, right? Yeah. And this tendon, it's still, I mean, even if we go in and do that debridement, there's still probably going to be some new scarring of the tendon that happens, long term. And so I still think that that's something they have to be prepared for, in the long run.
So on this patient, you can see here, if you look up on the top left, I did do a gastroc recession on this patient as well. There are some times where I will do an isolated gastroc recession for patients, and the research out there tends to support some good outcomes with that. And my cutoff is how much pain is coming from the actual bony prominence, the actual bony growth, because no gastroc recession in the world is going to remove the physical bone prominence that's rubbing in your shoe. Call it a pump bump, call it whatever you want, but there's a bony growth back there. There is no gastroc recession. Now, there's where the Zadig comes in and can kind of push that forward, and you could make an argument for that. Again, I'm not in favor of changing the function of something with the realignment, but at least then you're not having the bony prominence. But the gastroc recession, I will offer patients that. I tell them, hey, you've come to the point where we failed conservative measures. We have two options. We can do a simple procedure, knowing that it may not work. You may end up with the big one, or we can just take a dive off the diving board in the deep end and go for the big one. And I've had patients say, well, let me try the quick one, just the isolated gastroc recession, and done fantastic. Well, yep, my pain's gone. Great. See you never, hopefully. But, if you come back and you got the bone prominence, okay, well, at least maybe I bought you a few years, or who knows how long it'll last. But I will do an isolated gastroc for these sometimes, as long as the bone prominence is not the main driver of their pain.
Leland, what does your kind of preoperative discussion look like?
Yeah. So I've done quite a few of these, and I think when I first started doing them, I oversold how quickly they'd return to full activity. And it led to some, I guess, frustration where it was a good outcome and everything. There was no complications. It was just a slower recovery. So now I tell patients it's going to be 6 to 12 months till that foot feels like your own, where you can, run and be active and really not. And I say it's not a 6 to 12 month recovery. It's just, it's going to be weak. It's going to feel different for quite some time. And in my experience, in my hands, that's just been the truth. So I try to commit to that 6 to 12 months. I document it very clearly. And if we supersede that, if we come out ahead, that's great. But, most of the time it takes a while.
Yeah, I tell patients the same thing. I'm telling them 4 to 6 months, 9 months, up to a year for this. It really depends on their pre surgical activity level. If they're diabetic, obese, they're not going to bounce back as if they're, 33 and otherwise healthy. So the patient does, just like in any surgery, in any part of medicine, the patient really is the driving force. I don't do anything different. I'm going to go in and do the same exact thing that I did on patient A, B, and C, and they're all going to heal up at a different time rate based on, protoplasm and, metabolic syndrome or whatever it may be. So I think that's an important discussion for sure. All right, so this is a video of palpating the gastroc recession place. Kind of follow the calf muscle down, 2 fingers below that musculotendinous junction. Here we are opening up. Do you guys do I do an inverted T for my Achilles. Do you guys do anything different when you're detaching that off of the bone? An inverted T. You do that too?
Yeah, I split it right in the middle and then make that horizontal one distally.
Yeah, I think that provides good access to the very peripheral aspects of the bone. There's some bony prominence, and I've had people have very large osseous prominences that are way medial and way lateral, not direct posterior. And you don't really appreciate that on any x-ray. Even if you got a calc axial, you're going to be looking down the shaft and you can't really appreciate them very well. And then on the lateral, obviously, you see it going posterior, but you don't appreciate that large bump kind of on the posterior medial and posterior lateral aspects of the calcaneus. And the inverted T incision really allows you good access to get all the way over to each of those sides.
Yeah, I think if I have any that I've ever been unhappy with the outcome after the fact, it's been that I wasn't aggressive enough or didn't appreciate enough of that medial and lateral prominence.
Because sometimes you're chasing it way far. You're like, you're turning the corner. You're going way over there. And so if you don't make a big enough incision or reflect enough of the Achilles tendon on the medial and lateral sides, it's really hard to get over there. And so here we are kind of shaving down the osseous prominence. Do you guys use a bone saw or an osteotome?
I use a saw.
Saw.
Yep, I agree. And then I'm smoothing it out. So do you guys, so on a lot of times that I do a exostectomy, we'll call it, maybe like midfoot arthritis or a chilectomy, or anytime I'm taking a osteochondroma of the hallux, anytime I'm just shaving bone and I don't want it to regrow, I will commonly use bone wax. So in my mind, I don't want the bone to regrow and I want to put bone wax on this. But I do want the tendon to reattach to the bone. I don't want to create an interface where then the tendon is only reliant on the anchors into the bone, not actually attaching back to the bone. So sometimes I will put some bone wax in this image kind of distal to prevent some bony regrowth back there, but not at that more proximal area that I want the Achilles to reattach. Do you guys ever use bone wax or think about that? Or am I just crazy?
Well,
those
no
are
comment
two separate things. Yeah. How long is this podcast now? I think that's certainly a valid point. I mean, you'd hope also that if you're doing, potentially the gastric recession as well, that maybe you're addressing some of that tension, and maybe, mitigating some of the regrowth. But you're right. I mean, I think you're trying to hopefully see that tendon, kind of adhere down there again. So I have not done that, but I certainly don't think it's unreasonable.
Mm-hmm. So without mentioning any specific product names, do you guys also use this specific instrumented device to reattach the tendon back into the calcaneus, or how are you doing that, Leland?
Yeah, I like the knotless anchor system. I think since using this, I feel a little bit more comfortable getting them weight bearing earlier, range of motion earlier. Yeah, same reattachment approach.
Ashley, I'm pretty sure you do this as well.
Same, yeah.
Yeah, so we're tapping. We've got those sutures that we've passed up through the tendon. We're going to plug those into a couple of anchors, specifically 4 in this case, into the posterior aspect of the calcaneus. So here's the most important part, I think, of this is the tensioning. I don't know. What do you guys think about tensioning? Are you tensioning at 90 degrees, or are you doing something different?
Yeah, I try to just get physiologic tension, get the foot into a neutral position. A little bit of plantar flexion, you should be able to rehab out of that if you're in a little bit of equinus, but I try to get them neutral.
The benefit of doing that inverted T incision is that there is usually a small component of the tendon anteriorly that I try to leave attached to the calcaneus if I can. So I'm not doing a full detachment. I'm allowing some of that peripheral tendon and some of that anterior tendon to stay attached. So it is already kind of at physiologic tension, is my thought, is that if I fully detach and it's floppy, well, then I really have to lock that back in where it needs to be. But if I leave some of that attached, it's already going to kind of find its home. It's already going to kind of be where it needs to be. So we lock those anchors in there, and then we can see that the tendon has been debulked, debrided, and not a massive incision. We're I could have even made that smaller. I probably extended it too far proximal, but I do like to evaluate the tendon and debulk and take out some of that scarred garbage. Like you said, you end up taking about 50% of the tendon.
Mm-hmm.
And so by the time sometimes people do these little MIS things, I always think it's funny. People are so into MIS right now, and they're like, oh, I can do MIS. And then they're like, oh, just a 1 centimeter here and a 1 centimeter here and a 1 centimeter here. I'm like, you have more centimeters of incision than I do. If you just made one, I got a 5 centimeter incision. You got 7 little poke holes of this and this and this. It's just kind of funny what people are they get so caught up on something. Just open it, just be done, just move on. I don't know. What are your thoughts on that? You guys tired of hearing about all this MIS garbage?
I do think there are some limitations to MIS. I mean, I think there are some great indications for it, but I do think there are some limitations, and maybe some things that are just better left as an open procedure. Now, I do have a question. Are you guys fixing whenever you make that debridement in the tendon? When I first started out, I was suturing back together that longitudinal incision that I'd made within the tendon. And more recently, I've stopped doing that because I felt like I was adding this additional bulk with some non-absorbable suture. Are you guys repairing that, or do you feel like that's necessary?
Yeah, I mean, I still am. I do. I bury my knot, so it's not going to be too proud because the tendon there is fairly superficial. But yeah, no, I still am. Maybe I shouldn't. I don't know.
I've moved away from doing that. I agree with you. When I was first out, this particular product comes with some suture tails,
exactly,
also in the anchor, and I used to kind of run that up to kind of fix that. I've moved away from that. I will just use an absorbable suture, maybe a monocryl or even a vicryl, but monocryl. So I moved away from that because I found the exact same thing. I was running this big thing, and then I'd tie these knots down, like, all right, that's not going anywhere. And there's it was knotless until I got a hold of it, and I put a bunch of knots in there. It's like, wait, hold on. I'm doing more harm than good. So I haven't had any problems with that vertical incision through the tendon itself. Just repair the peritoneum carefully. Sometimes you can make an argument to tag the peritoneum with an absorbable it doesn't matter, absorbable, non-absorbable, just to tag it with a stitch there, and then reapproximate that when you're closing. So I've moved away from doing that, but I certainly used to do that, and I don't think it's wrong. It's just you got to be careful. Are you creating a new problem that didn't need to be there?
All right, I'm convinced.
You don't want to be like me.
Yeah.
You don't want to leave all these giant knots in there. All right, so moving on to kind of the belle of the ball, the percutaneous Achilles tendon repair. Do you guys do these? Have you done this surgery or not?
No, I still open them.
Okay. Ashley?
I open as well.
Okay. And so if you're doing an open approach, which I think is still very reasonable, the biggest downside to me to that is that you're relying on your knots. You're relying on your suture to hold the tendon together. And when you do the percutaneous approach, you are kind of bypassing the tendon to tendon interface and jumping to a tendon to bone interface. What kind of suture, Leland, are you using? I don't even pretend to remember them all because I haven't done them in so long.
Usually orthocord, Ethibond suture, one of those two non-absorbables.
And are you kind of doing like again, I'm not an
more of a crack out type stitch, a little bit more of a locking stitch.
Sure.
And then maybe reinforced with some absorbable sutures on top, maybe wrapping it with some kind of biologic if needed.
I think that's very reasonable. I think that's been kind of tried and true for a long time. Ashley, how are you suturing yours?
Yeah, same. Utilizing more of a crack out approach for those.
Now, knock on
wood. And probably to be fair to and more transparent, like I don't see enough acute Achilles ruptures in my practice to climb that learning curve of doing it MIS wise. So again, I'm just not seeing as many acute ruptures. If I were seeing multiple, I might consider changing my approach, and maybe that's quite reasonable. But again, I just don't have that practice right now.
So I do understand that I just badmouthed MIS, and then I'm telling you how I fix this with MIS. So I do fully understand the oxymoronic nature of what I'm saying. So maybe I'm just kind of a pick and choose type of guy, but I think these are a little different. To me, the chronic insertional Achilles tendonitis needing to debride the tendon outweighs the benefit of the MIS approach, whereas in an acute rupture, if I don't need to open it, I can get by with smaller incisions because I'm not having to tackle that large osseous prominence or the thickened scarred tendon. So maybe I'm more of just a pick and choose type of thing here. So specifically, we're talking about the percutaneous approach. And again, we're not sponsored yet by anyone. I'm sure we will. We'll probably take off and we'll get pretty famous here pretty soon, and we'll be sponsored, but we're not famous yet. So we're not advocating for any one particular company. This is just the one that I use. So you go ahead and insert the jig with the number one crossing pin across there with the wire to hold that in place. So one of the pearls here that I have for this is that it's important to mobilize the tendon as you insert the jig. So as the jig goes in, you want to be able to mobilize the tendon independently from the jig. You want the tendon to be able to slide inside of the jig itself so that you can pull the tendon a little distally. You want the jig to stay put and you want the tendon to be able to slide distally. You want to pull a little bit of traction on that pulls it tight so that when you throw your wires across through the jig, that it maintains tension. If you don't do that, when I first started using it, I found that the wires would want to not go through the tendon. They would want to slip and go kind of, I guess, technically posterior to the tendon, but in our case, superior because of how the patient is prone. But those wires would be above the tendon itself and not getting a good lock through there. So you want to make sure that you mobilize the tendon and you kind of squeeze the tendon on the sides to kind of bulk it up when you throw your wires through, so that you are getting a good bite through the tendon itself. And so as you insert your wires, you're also passing suture through those in a specific orientation. You don't really need to memorize it, although if you do enough, you will have it memorized, but they should be well versed in telling you which order to put the wires or not the wires. The wires are going 1, 2, 3, 4, 5, 6. Well, it depends on if you're using all the wire holes or not, but at least the first wire holes go in order, and they'll tell you what color suture to put in each of those. So once you've passed all the wires and passed all the suture, the most important thing is to not get them tangled up. You don't want them to kind of be inadvertently tangled. So as you put them through, you kind of lay them off to the side in the same order that you put them in, because eventually you're going to need to have them in that order for the stepwise approach of what you're going to do next. So keeping them in order is important. Maintaining that jig in that same plane is important. Sometimes you want to hold the jig, and if you hold the jig is going to kind of plantar flex or tilt down a little bit, such that your first suture throws are deeper, and as you go distally or come toward yourself, then the jig will be plantar flex, and some of those stitches will be a little superficial compared to the more proximal ones. So you can see here how that jig is staying pretty well flat along the linear nature of the Achilles tendon, so that all of your sutures are in the same plane or same level. That becomes important when you start doing the next step, which is pulling the jig out, and all of those sutures are coming out through the incision. Have you guys done a lab or played around with this jig?
No,
I have not.
It makes a lot of sense. It's rather complicated, but whoever invented it is pretty smart. They came up with a good idea. So here you are locking the sutures. We're not going through details of this, but you're kind of going over and then through a loop and pulling it from one side to the other, and then over and through the loop on the other side. And after you do that, you want to test your construct. You can see that we have really good mobilization of the tendon as you're pulling distally. We can see that moving. And then the difficulty with this was that this is the person who had that MRI that showed the very, very proximal tendon tear with the large retraction. So that allowed me to place my incision. So according to the technique guide for the percutaneous, they tell you to make a horizontal incision. I don't like that, because if you make that at the wrong level, you're kind of screwed. I make my incision vertically. You can still fit the jig in, no problem. But if you're not quite at the right level, you can extend your incision. You could even turn it into an open approach if you were just, if you had to bail out. But if you do that horizontal and you had to extend it, and you got like a Z or something, it's just not ideal. So I do go ahead and make a vertical incision there. But because this tear was so far proximal, I couldn't get the suture passer from the heel all the way up to the tear. So I had to make these kind of little accessory incisions along the side and bring them down out these accessory incisions, and then eventually go down to the heel bone and pass them out next to the heel. So this was the first time I've ever had to do that. I had a tendon tear that was proximal enough that I had to make accessory incisions and use the suture passer 4 times, so 2 on each side, as opposed to just doing it twice. So it took a little bit longer, but my tourniquet time, I think, was 40 minutes or so. And so after we've got the sutures coming out, those distal incisions, you can see that we have the tendon mobilized. You want to test your construct before you go ahead and anchor them in there. Inserting the anchors, very similar to when we're doing the detach reattach with the anchors, very similar construct. We're going to anchor those into the heel bone to lock it into place. So the interesting thing about this construct is that we are not relying on tendon to tendon approximation. There is a way that you can do tendon proximally and then tendon distally and then tie those together. I typically will just go tendon proximally into the bone. And I've been doing that for 10 years. And I don't tend to see any issues. We're kind of bypassing the nature of that distal stump. We're mobilizing the proximal tendon. We're advancing that distally as far as we can. But you saw in the MRI, with that amount of retraction of the tendon, it's going to be very difficult on an open approach. You're gonna put a couple Alice clamps on that proximal, and you're gonna pull on it, and it's gonna be like you're gonna water ski, and it's gonna go nowhere. It's gonna like pull out, right? You're gonna have a really hard time advancing that far distally. So that's one of the benefits of doing a tendon to bone construct, is you're kind of bypassing the tendon to tendon reapposition. As long as you tension it appropriately, I don't care whether the tendon ends are fully together or not, because of the amount of retraction and kind of shredded nature of the tendon itself. I know that I've tensioned it appropriately, and then the rest of it will heal almost as if you did a non-operative treatment. We know that a tendon will kind of fill in the void, the gap, the hematoma, all that stuff, convert itself to tendon. So that's kind of happening on top of my tendon to bone interface. Ashley, what do you think? Did I convince you you're going to go for the percutaneous approach?
I don't know. I'd say similar to Leland at this point. I don't see these enough in my clinic, maybe to play around with it too much. I mean, there's still something about being able to visualize both ends of that tendon, see the repair come together, that just makes me feel much more, confident in that. I think I can appreciate where you're putting in the bone anchors and whatnot with this, but still something about those blind passes through that tendon that just I'm not sold yet. It's interesting though.
I've got some work to do. Leland, are you changing anything, or are you sticking with your tried and true?
I think there's definitely room for this. It's a technique that seems to have quicker return to full activity, especially in an athlete or athletic population. But yeah, no, I mean, there's definitely a learning curve to be able to do it well.
Yeah, I think that's reasonable. Yeah. Have you guys ever done anything out of the ordinary? A Murphy's? We talked about the Zadig or whatever.
No,
anything that we're missing?
No, I mean, I think more for like spastic Achilles issues, I think is more of the Murphy or advancing it anteriorly. I personally haven't had to do that. One thing that I've been disappointed about is I've never taken a history with someone who has a rupture and they just took a fluoroquinolone. And I want that to happen someday in my career. It just hasn't happened yet. I was so ready for it.
Yeah.
Mm-hmm.
What about you all?
I've had one.
Yeah.
And he was not happy.
No,
when he found out that could have been the reason, he was not happy. Luckily, it wasn't me who gave the fluoroquinolone. It was for some unrelated body, infection. But anyways, he was not happy. So especially when they realize, did I have to be on this? No comment.
Yeah, right. That's when you keep it shut.
Yeah. I don't know. Have you seen that, Ashley? Have you seen fluoroquinolone?
No, but that is definitely one of those like board kind of question things. Yeah, I haven't had that yet either.
Same with like my gout people. Like they usually don't come to me after a night of beer and shellfish.
Yeah, you wish they did. You wish everything fit like into its perfect little puzzle piece in your mind. You could put it. Oh, I know what you have, right? Yeah. And it just doesn't seem to work that way.
Not usually.
Yeah. All right. Anything else you guys want to add on either chronic or acute Achilles tendon injuries? Did we touch on everything?
No, I think that was pretty comprehensive.
Yeah. I mean, I would just say I don't think we went too much into, the surgery or not, the kind of non-operative, early rehab kind of side of things. So certainly we were, a little bit more surgery focused today, but there's certainly, I think, an argument for a lot of these for the benefits of non-operative management with early rehab and the outcomes, especially in some of the newer studies with that more aggressive early mobilization, even with re-rupture rates, that kind of gap is much smaller compared to some of those early studies and 6 weeks of non-weight bearing or whatever it may be.
So you're talking specifically on the tears, obviously, because we talked about the measures for the chronic kind of, PT and stretches and all that stuff. So you're talking about the tears that come in and talking about non-operative treatment options. Yeah, I think, it used to be, I used to have the numbers 9% and 3% memorized, which is, I don't know where I got those. It could be completely made up in my head. I could have had no rhyme or reason to actually have any scientific evidence that backs that up. Some say 9 to 3, some say 3 to 1. I would just say a 3 times higher risk of re-rupture in non-operative treatment versus operative treatment. Do you guys, here's an interesting thing we didn't touch on. What is your thought on DVT prophylaxis for Achilles tendon ruptures, both operative and non-operative? Leland?
Operative, yes.
So specifically what, though? Aspirin or Lovenox? Or are you going above and beyond the aspirin?
Low molecular weight heparin, Lovenox. Yeah, I almost exclusively, unless there's a reason why they can't be on it based on other factors, but Lovenox for me.
Ashley?
Yeah, I mean, I think certainly you're opening up a whole other can of worms talking about DVT, Jeffrey. So yes, I mean, I would agree.
There's only 2 people on this planet that call me Jeffrey.
I would agree. Generally, I think Lovenox is definitely a good option for these patients. I think there's a place for some of our oral medications like Xarelto and whatnot. But yeah, definitely. I think prophylaxis is.
I mean, I've had like a few PEs in my patients, and for some reason, it's always when I'm doing Achilles work.
Yeah.
So maybe that's just made me a little more fearful, but yeah, no, I use it pretty consistently.
Certainly a higher incidence when you're. It makes sense. You're back there messing around, and if we're going to get a DVT, it's in that posterior muscle group, so it makes sense. The literature doesn't really support that. When you look at the high-powered studies from meta-analysis and systematic reviews in terms of foot and ankle surgery, they really don't recommend anything. I don't know that I feel comfortable doing nothing. I tend to do aspirin. We're getting off base here, but let's keep it to Achilles talk. I usually do aspirin at least. And then for an Achilles surgery, I do Lovenox as well. So I don't think you're ever wrong to do it, for especially, for Lovenox. Versus some of those stronger antiplatelet medications. If they were to have a fall or have a complication, then you're certainly, going in the other direction. Why'd you do this when the literature doesn't support that? Sometimes there's no right answer.
I think you can't go wrong with when you're pre-oping your patient. Just do the pre-test probability with like Wells criteria, Caprini scales, whatever you want to use. But I think as long as you address it preoperatively and identify there's risk, then you really protect yourself. So maybe it's wrong just saying indiscriminately everyone needs Lovenox that has an Achilles rupture that's repaired. But I think going through that pretest probability is probably the more appropriate way to assess risk.
Yeah. I think the risk stratification is the key component for all of our, decisions regarding prophylaxis.
Let's save DVT for another show, though.
Yeah,
we could definitely go down the rabbit hole.
It's a good topic
for sure. Yeah.
So, luckily we got a whole lot of topics we could touch on. So we got many episodes to come. So real quick, I just have to shout out my t-shirt, the band Camp. If you don't know Camp, CAAMP, big fans. So shout out to Camp. All right. Thank you for joining us on this episode of Pod Patrol with your host, Dr. Jeff Dykes,
Dr. Leland Jaffe,
and very special guest host,
Dr. Ashley Dykes.
Did you forget your name for a minute?
I like that one.
All right. No headphones. All right. Yeah, they got to charge those things up. All right. Until next time, thanks for joining us on Paw Patrol. We'll see you next time.
Take care.